Hi, I'm Dr. Robert Coffin, and we're about to go beyond the Terminus. Cracked teeth present some of the greatest challenges to dentists. Why? Because one of the decisions you have to face is how cracked is too cracked to consider treatment. Cracks come in various forms. Enamel craze lines, which generally aren't treated unless they're cosmetically objectionable. Horizontal or angular fractures due to trauma. Cuspal fractures. Marginal ridge fractures. And fractures that most often extend mesiodistally across the tooth, though they can extend buccolingually in rare cases. In my earlier practice years, I used to treat a lot of cracked teeth more aggressively. The typical scenario involved a mandibular second molar or terminal tooth in the arch, usually with at least a one or two surface restoration and a distal marginal ridge fracture that extended deep into the canal orifice. Many of the cracks were stained due to oxidation products of the amalgam restoration or hydrolysis of the dentin bonds of the composite. Most of these pulps were at least partially necrotic, and many had radiolucent findings associated with the apices, usually in the root closest to the fracture. The critical factor seemed to be whether there was bone loss and probings associated with the crack. If that was the case, prognosis was poor. Even in cases where the pulp was vital and the tooth restored fairly promptly with a casting, fractures such as this can fail periodontally, usually at around 5 to 7 years post-op in my experience. We have to be very careful when we consider incorporating such teeth into a treatment plan and relying upon them too much long-term. Teeth restored with MOD-type restorations and heavy occlusion show a particularly high risk for cuspal fractures and catastrophic mesiodistal split. Many times, fractures develop under proximal boxes and either extend to the canal orifices, like MB2 in maxillary molars or distal canals in mandibular molars. Teeth with fractures in both marginal ridges that meet on the furcal floor require extraction. A lot of the time, the leakage causes the furcation to break down periodontally, which is one radiographic clue. Another clinical clue is that one side of the occlusal portion of the MOD restoration will show an open margin or debonding and discoloration, usually on the buccal or the palatal side. The ditching or discoloration on one side will be exaggerated in comparison to the other side of the restoration. For example, a buccolingual margin of an MOD restoration will show separation from the tooth. That's occurring because of the flexing or the opening of the buccal and lingual cusps during chewing. Combine this with furcal breakdown and a long-standing lesion of endodontic origin, and you often have a non-treatable split tooth. So, if you insist on trying to save a cracked tooth, how best to do it? Well, before you start, you must get consent from the patient, and they have to understand you're working on a compromised tooth with an uncertain prognosis that may become clearer once you've explored the fracture. Let the patients know that if you suspect the tooth has a poor prognosis, you reserve the right to cease treatment and recommend extraction. Firstly, remove the entire restoration so you can see the extent of the cracks clearly. You really need a good light source and high levels of magnification for this. Secondly, if you do endodontics with a multi-appointment technique, or if the tooth cannot be restored immediately, to prevent catastrophic fracture, you have to provide support for the tooth, either with a custom-made copper band, a stainless steel ortho band, or some sort of temporary aluminum shell crown. Thirdly, explore the fracture after gaining access to the chamber. Examine the width, the length, and the color of the fractures. I emphasize again that you need a good level of magnification and a strong light source such as a surgical operating microscope to do this properly. I'm sorry, but 2 to 3 time loops with a standard operatory light or head-mounted light will not do. This is one of the reasons I am not in favor of the so-called minimally invasive or ultra-conservative access in such cases. Misguided attempts at conservation of tooth structure limit the visibility and our ability to examine and evaluate the extent of the fracture, which ultimately influences your decision whether to treat it or not. Trace the mesial and distal cracks down the chamber to the furcal floor or orifices. If the mesial and distal cracks join, the tooth should be extracted. If they do not, you'll have to decide, along with the periodontal probing depths and radiographic evidence of bone loss, whether this tooth merits continuation of treatment. You can try to use dyes such as methylene blue and ophthalmic dyes to stain the crack, and ultimately a well-dried access and 10 to 15 times magnification probably will give you the best idea of the extent of a crack. Fourthly, if you see a crack entering an orifice, and use a warm vertical compaction obturation technique, you may want to ease up on the condensation pressure or use a different obturation technique to lessen the risk of crack propagation down the root while you fill the canals. Lastly, relieve the occlusion and ensure the tooth has a cusp-protected restoration placed as soon as possible. Even still, treating cracked teeth is always a crapshoot and has a certain level of unpredictability. It's important to discuss the role of the tooth in the overall treatment plan and the level of risk that is acceptable to the patient. Even though these may be treatable endodontically, it doesn't necessarily mean that you should be treating them and restoring them. These teeth should not be used as any type of fixed or removable prosthetic abutments. In the implant era, it may be more prudent to consider extraction and re-evaluation of the restorative treatment plan rather than risk loss of a critical supporting tooth. In all cases, at any clinical treatment decision point, patients should be given the choice of whether they wish to proceed with treatment, rehabilitation, or extraction. Remember, when we do the right thing, we both get better, patients and clinicians. Thanks for listening, and join me again when we take another trip beyond the terminus.